and mentors and enablers. I'm not very good at statistics, so I have a very good statistician that works with me. We need a team, as I said before. We need the team for skills, but we also need a team because that's a fun way to do research. And to do research, you need passion and you need to be able to enjoy yourself. So all of these things are really important. The last thing I have here is relatively new, and I'm sure you're aware of it as well, and that's consumer engagement. So before we answer the questions that we wanted to answer, now we think more about answering questions that families and children want answers to as well. So that very much shapes the research that we do. So to do impactful clinical research, as I said, we need a question. And I'm just going to take you through in this talk how we get these various components of what we need to make a difference. So we need to study the literature. We need to work with families, as I've said. We need to collect data, so clinical trials, observational studies, and so on. Usually we stop at this next stage. We usually stop with publishing a paper or perhaps creating guidelines. But I want to encourage you to think about in what you do as clinicians and as researchers, translation and implementation, so actually making a difference, making sure that what you do gets translated into practice. And later on I'm going to give you an example of a student from Mexico who came to work with us, who actually managed to do that. And hopefully improve care. But what Google tells us is to do that it takes 17 years. So that's a long time. Hopefully in the future we can do it more quickly. So that's at a general level. Now I want to focus down and talk specifically about children. And why are we interested in children? None less than adults, so that's why I think working with children. And they're fun to test, although I'm getting a bit old to get down on the floor with children these days. But I've listed, and you'll have this on your phones, that we really need to think about the fact that children are not just small adults. Their brain's developing very rapidly, but at varied rates. Their skills are emerging, both cognitive and social and emotional. And more importantly, there's a greater opportunity to intervene and make a difference to improve outcomes. And that's really my focus. So, to understand what happens after a brain injury, we need to understand normal development. And I'm sure you all are very well aware of how the brain develops. So from the neural tube to something that looks like a brain but has no sulcine gyri, right through to the brain that we're more used to. That developing brain, the critical point I want to make here, is that developing brain is very vulnerable. So it's vulnerable to genetic factors, to environmental factors, and if any of those factors are in play, then development won't go along the typical genetic blueprint, and we get a surprise, I suppose, in terms of what happens. And more importantly, when we're talking about children, the functional neural networks that are developing are absolutely critical. And those of you that work with children will know that we don't often see focal disorders such as aphasia, but we will see general disorders in all of these areas: information processing, working memory, planning, regulation. So much more generalised problems than you might see in adults with the same condition. So, the other thing that's really important is the environment. And there's just a couple of examples here. I might just focus on the one on the left, which is an old study from Brian Cole, who's a very well-known neuropsychologist who works with animals. And he did an interesting study, which you can look up, where he raised some of his rats in normal lab cages and some in these very nice condominiums that were very stimulating. He had old rats and he had baby rats. Then he sacrificed the rats and saw what their brains looked like. See on the right of that little condo is that the rats that were the baby rats that were raised in the condos had much more connectivity in their brains than those in the lab cages. But for the older rats, there was no difference. So the young brain is susceptible to environment and responds to a good environment. And the second graph over here is just showing the same effect, but with parenting and brain connectivity again. So the high quality the parenting, the better the brain connectivity. But what happens when we disrupt the brain of a child? So these networks can be derailed. There are limitations for the child in terms of developing new skills. They've already got a limited repertoire, and there may be delays and deficits, and also difficulties with mastery of skills, as you'll see in your patients. So, I'm not going to go through this list, as you're all neuropsychologists and you know what the problems are after a brain injury, but just noting that not all children have all of these problems, but they will all have some after a brain injury. So just to put this in the context of the cases that we see, I want to talk to you about Lockie. So Lockie, this isn't a real picture of Lockie, but Lockie was 3 years old when he had an accident. He was with his dad on his farm, on his tractor. He fell off the tractor and the tractor wheel went over his head. So he had a very nasty injury. So he was 3 years old. You can see from the scans that he had severe injury with frontal pathology. He had late onset epilepsy, which created additional problems, but he had a well-functioning family who supported him. What I really want to point out here is the images. So you can see the acute image here where he's lost brain tissue, so it was an open injury. Then, 10 years on, we see the same injury with very little, if any, recovery. The thing that's different in early brain injury is what we see here, which looks a bit like atrophy within the damaged hemisphere. This doesn't happen in adults. This is specific to kids, and it's now been shown by Harvey Levin in some research that's group-based. So what this tells us is that there's an ongoing process after a brain injury, after a severe brain injury in children. So this is his results on an IQ test. This is what we would expect for his age. This is Lockie's results. So the gap is increasing between what's expected and how he's developing. And then I'll add in some other skill areas, and just to emphasise that increasing gap is true across all of these areas. So language, memory, motor skills, all have this gap. So again, I won't go through this list because Lockie had pretty much all of the problems that we talked about earlier on. So Lockie, as an adult, was unable to finish school. He was unable to be employed. He worked at home with his dad. He had very few friends, and here's one of those outcomes that was really very poor. And what we want to know is, can we improve these outcomes? So, to be able to improve those outcomes, a number of steps. First of all, we have to generate knowledge.
Así que para mejorar esos resultados,
Then we have to disseminate the knowledge through guidelines, through technology, through trials. And we do this in the context of co-design with clinicians and with families. And we have to make sure what we're doing fits into the model of care that's being used. Hopefully then we'll get better outcomes. So let's start with generating knowledge.
sí, comencemos.
I'm sure you're all aware of the debate around plasticity versus vulnerability of the young brain. So I won't go into it in great detail, but a lot of the work that we've been doing is around this particular question, and I'm going to show you some data to give you some evidence around what we think is happening in terms of this plasticity vulnerability debate. What I learned very early in my career was that no idea is ever new. It's always been thought about before. And these people, who some of you will be aware of, all worked in this area of plasticity from the earliest stage with someone like Margaret Kennard in the 1940s. So I would encourage you, when you're looking at areas of research or when you're trying to understand the evidence for a particular perspective or particular condition you're looking at, go beyond what's on a computer and go back and have a look at the old literature. What you'll find is that many of the questions you have already been answered. So I'm going to show you 3 pieces of information about injury severity. First is traumatic brain injury. The second is cranial radiation for leukemia. And then the third is back to traumatic brain injury. And for the first 2, what I want to point out is the dose-response relationship between severity and outcome. So these are IQ scores. And what you will see is that this is the mild, moderate and severe group. So the more severe the injury, the worse the outcome. And here we're looking at the level of radiotherapy. So again IQ, and the more severe, the higher dose is the black line, slightly lower dose is the red line, and then the blue line is controls. So both of these, the core of both of these is that the more severe the injury, the worse the outcome. And the last one I just put up here because it's showing that there's a relationship between this kind of IQ outcome, and in this case social skills, and what's happening in the brain. So in traumatic brain injury, thinner corpus callosum associated with poorer social skills. By saying, this is what we would expect in adults too, so this is no different to what we see in adults. A couple of examples that are a little bit more outside of our area. So this is biomarker results, so indicating metabolic changes after a brain injury. Oops. So this is the healthy controls and the mild group. No differences. Moderate and severe group, there are abnormalities in metabolism that we can pick up in the blood. And then if we look at neuroimaging, this is some DTI analysis. And again, what I want to point out is in every one of these cases there's different metrics. The mild and the controls look very similar, and it's just the severe group that is most impaired, has the poorest connectivity. So I want to talk to you just quickly about 2 cases. So one has a focal injury, one has a diffuse injury. So moving on now from injury severity to the type of injury. This is relevant for child stroke and so on. So you have the details on your phone, so I won't go into it in too much detail, but you can see that they're very different kinds of injuries. So IQ scores for the 2 for the two boys. So Jacob, the focal injury, and these are his IQ pattern. At 2 months, he's having real problems in the spatial area, but by 10 months he's actually improved quite a bit, except that he's slow. For Michael, who had the more diffuse injury, as well as a focal injury, what you'll see is so initially his language skills were good, his verbal skills, but 4, 12 and 3 years, by 3 years he's much worse across the board. So global problems across the board that are increasing over time, a bit like blocking. So are you familiar with the rate figure? Yes? Good.
Thank you for the presentation.
Okay, so just to give you a little bit more quality, this is Jacob's rate figure at day 12, post-injury, and then at 10 months. And at 10 months, it's pretty good. Then we look at Michael. So this is his injury at his rate figure at 4 months. And this is at 12 months. Now that looks really good. But he told me was that he was practicing this in his occupational therapy every day. So we have a second version of the rate figure, which I gave him, and this is what he did. No better than this one up here. The therapist had taught him to do the rate figure, but it didn't generalise. So the diffuse injury, very significant effect. So you can see specific injuries, much better chance of, focal injuries, a much better chance of good recovery than diffuse injuries, as you'll again see in adults. So now we have more severe injury, more diffuse injury, both bad for outcomes. So now the third area with respect to injury is age of injury. This is the area that I've done lots of work in. So I'll go through quickly these graphs. So this first one shows IQ over time, up to 2 years, of an early brain injury and a late brain injury group. So before age 5 and after age 5. And you will see that the older group is doing better. This was my first paper ever, and it wasn't a very good study. So we thought we'd better do a little bit more. So this is the same data I showed you before, but with the groups divided into those who had their injuries before age 5 and from 8 onwards. What I want to highlight is for the mild group, age made no difference. For the moderate traumatic brain injury group, very small difference. For the very young children, a very big difference. So again, like Lockie, a growing gap in abilities. And so this is the same data that I showed you before, except I've divided the children into under age 3, 3 to 5, and older. So under age 3 is the first bar, 3 to 5, then 5 and over, and healthy controls. And what you see there is, again, the children under age 5, and particularly the children under age 3, are doing worst. And then this very last one here is a bit different because all those others are diffuse injuries. Now I'm looking at focal injuries. So this is a group of about 160 kids who had focal injuries. And they're organised in terms of, from the left to the right, the age at which they had their insult. So from pre-injury right through to late childhood. And on the very right, that's the normal kids. The green bars are the percentage of the age group that have severe impairments. And what you see, similar to the other groups, is that those kids under age 3, when they have their insult, are doing worse. I should have said they're all aged 12 at the We can't do anything much about the injury once it's happened, but we can do something about the environment. And so I want to just, the third area I want to look at is the environment. This is some very early work from Gary Taylor. And what he did was, with his traumatic brain injury sample, he divided them into high socioeconomic status and low socioeconomic status. And the groups are severe, moderate, and then orthopedic controls. And what you see in the high SES group is far fewer behaviour problems. So we're looking at behaviour problems here. Far fewer behaviour problems, not such an effect of injury severity. Whereas in the low socioeconomic group, there's a big difference. So we come back to that dose-response relationship where the children with more severe injuries are having minimal behaviour problems. And this is called a dose-response relationship, where a double has a severe head injury plus low socioeconomic status or social disadvantage. So we can't do much about social economic status either. But what we can do something about is family. And the reason why we started working with family is because of this kind of data. So on the left, you see perceived parent burden after a traumatic brain injury. And you see it increasing with injury severity, but also increasing over time. So the grey bars are 30 months. So ongoing parent burden, and across all areas, across their relationships with their family, with their spouse, with their children, and in terms of quality of life. And if you look on the right-hand side, this is the group of kids that we've now followed up for 25 years. This is early on, and what we see is a division for us where we looked at the children who had clinical level behaviour problems versus those that didn't have any behaviour problems. And what predicted those with clinical levels, you can see here. So injury severity, yes, but family burden, family function, parent stress, and maternal depression all predicted which group the child fitted. So what do we know? We know that there's affective biology, so injury severity, injury location and complications, development, and I've talked to you about development at age of insult, but we can also look at other factors. And then environment, distal factors like social advantage or disadvantage, and then family factors or proximal factors. And what they tell us is where on the continuum between plasticity and vulnerability the child will fall in terms of their outcome. Injury factors more important acutely, family factors more important in the long term. So mostly when we look at research, we look at IQ and executive function. I'll let you read through this for yourselves. But I really just wanted to point out that there are many other areas that we need to worry about. We need to worry about social outcomes. They're very much dependent upon the child and the family factors, both pre-injury and post-injury.